A very warm welcome, everybody, to our second webinar series of the Impact Research Group at UEA. And our focus in this spring-summer series is on reinvigorating the system for COVID recovery. And today I'm delighted to be joined by a panel of experts who are going to be working with us to present some key insights on health systems transformation, and I'll introduce them in just a moment. Could I just ask you all, please, as this session is being recorded, to ensure that your camera and microphone are switched off and that you use the chat function to ask any questions or make any comments that you would like to make. So this session today is an hour and a half until 1:30, and we're going to hear from our panel first, and then we're going to invite you to help us address a number of critical questions that we think are really important in terms of systems transformation. And we're going to use a creative Mentimeter exercise for that and invite discussion. I'm joined today by Professor Jonathan Webster and Professor Sally Hardy, who are co-directors of the Impact Research Group with me, and apologies from Professor Kim Manley, who's actually on holiday today. So on our panel, we have Phil Carver, who is Regional Director for the East of England for Health Education England. Phil has a portfolio that covers multi-professional workforce agenda, including medical education and training, quality, integrated strategy and transformation. He's held a number of senior academic positions across several universities in England and Scotland, and latterly a director role at the University of Sheffield. He's joined by Gareth George, who is Head of Education and Transformation at Health Education England, East of England. And Phil and Gareth are going to be presenting first. Then we will hear from Paul Roach, who is currently the Programme Director for System Workforce Improvement, working with all 6 integrated care systems across the East of England. In this role, he's supporting the ICSs to understand their workforce priorities and support the development of plans to accelerate workforce capabilities. Paul brings a breadth of experience in both private and public sector organisations, and in particular has significant delivery experience in both strategic and operational roles within the healthcare system, leading organisations and systems through some very complex transformational changes. Then we're going to hear from Dr. Lynn Wiggins, who's Non-Executive Director of Allied Health Professions Suffolk and Visiting Professor at the University of Suffolk, Honorary Professor in Health Studies at the University of East Anglia. Lynn is a Registrant Council member on the NMC and a trustee of the Royal Osteoporosis Society. As a CNO exceptional leader, she's been working on the career pathway for chief nurses and directors of nursing and midwifery. She was the East of England Regional Chief Nurse, and before this was Director of Nursing and Quality at the Ipswich Hospital NHS Trust, and prior to this, Director of Patient Safety and Clinical Quality at NHS Suffolk Primary Care Trust. And then we're going to hear from Helen Oliver and Jessie Cunnett. Helen is Chief Operating Officer and Deputy Chief Executive for Eastern Academic Health Science Network. She's responsible for overseeing the company's operational processes, including corporate functions, and leading the development of business strategies and reporting. She's particularly passionate about co-production and is leading the organisation's PPI strategy and champions it across stakeholder organisations. She's joined by Jessie Cunnett, who's Head of Health and Social Care at Traverse Limited. And Jessie established Patient and Public Involvement Solutions in 2008, which was a specialist agency working across health and care systems locally, regionally and nationally to support and promote the voice of patients, service users and the public. She's proud to have been selected to lead a number of nationally significant projects, such as rebuilding relationships after the failings in care at Mid Stafford's Foundation Trust. So we're going to move through the presentation, and Phil and Gareth are going to be talking to us about regional and national priorities for workforce transformation. And then Paul is going to present some headlines from the SWIM project, followed by Lynn, who's going to talk about the particular challenges for executive leadership in ICSs. And then Helen and Jessie are going to talk to us about citizen engagement and innovations in public patient involvement. So I am going to hand over, first of all, to Phil and Gareth to ask them to come onto camera to present their slides. Thank you.
Thank you, Carrie, and good afternoon, colleagues, and thank you for your time. If we move to the next slide, just to be able to give colleagues just some time to reflect over these points while we probably give a bit of context, if that's okay, and then Gareth to give the regional priorities as well. I thought it would just be important just to help with setting the scene of this discussion around where we are nationally. And currently there is in the white paper, integration and innovation, working together to improve health and social care for all. It sets out the legislative proposals for a future health and care bill from into effect from next April 22. And what does that mean? There'll be a duty of collaboration across health and care system. And it's really about that triple aim for NHS bodies and including the integrated care systems, of which there are 6 in the east of England. And those triple aims are for better health and wellbeing for everyone, better quality of health services for all, and
Phil, you've gone on to mute.
I apologise. I thought I'd come off mute. It's I'll start over again if that's okay. And I apologise for that. That's my I've only been using Teams for a year. So I was just detailing actually in the white paper the proposals, the legislative proposals currently for a future health and care bill to be effective from next April, and with the duty of collaboration across health and care, the triple aims, and they're around better health and wellbeing for everyone, better quality of health services for all individuals, and also the sustainable use of resources as NHS resources as well, which plays really on the role of the anchor organisation. And that duty of collaboration is really across the across ICSs, of which there are 6 in the east of England. Additionally, ICSs will also help the NHS support broader economic, social development. And also it's got, I think we need to call out that these duties will build further on the service and health priorities. And clearly what we learned through the pandemic in terms of the future demand for healthcare workers, sustainability of supply and longer term education and training objectives as well. So clearly a period of change over this next 9 months, and also being ready for the legislative change from post-April as well, but really a positive environment to work in, certainly as we move in an era for the 6 ICSs in the east of England and those emerging priorities around transformation as we move forward. But if I hand over to Gareth to take us through some more of these priorities in detail on this slide.
Thanks, Phil. So we've just listed here many priorities, but listed here a few of the areas we're focusing specifically within East of England over the next year to 2 years. And they're not in any particular order, but I'll try and link them together. So one of the things we're particularly focused on in East of England is how do we develop the capacity and capability within workforce planning to identify what that workforce should look like in the near and medium and longer term future. And so we're conscious that with all the systems, and as Phil just described, the focus on our systems, system first, that leadership, and then Paul will talk a bit more about SWIM later on. Having that capability and the capacity to identify the workforce we need is really critical. And once we've got that, and we recognise that workforce will lead to a growth in numbers, not just more of the same, but different types of roles and the way that workforce will operate and the ways of working across different service models as they're developing, both out of COVID, but also as patient needs and population health changes. having that plan and then understanding that growth, where we need to get to, and achieving that sustainable growth is impacted significantly on, well, for East of England, our current capacity for clinical learning. So even if we could plan the workforce effectively and know what we need, we do know that we are struggling within East of England around sufficient capacity to train both non-medical and medical students and trainees. And so one of the focuses for us in East of England within that transformation space is how we create sustainable clinical learning opportunities across all our organisations and different sectors in health and social care. So those three together around having the capability to plan effectively, identify the growth and achieve sustainable growth is fed by that clinical learning opportunities. And then we mustn't forget that existing workforce that we have around the retention, but that workforce development piece around how do we develop our existing workforce to not only deliver services differently, but build their own skills and competencies and confidence to do things differently, work in different ways, and support that new workforce coming on board and support the learners within that increased learning environment that we've just talked about. So those four elements together around understanding the workforce we need, identifying the growth and achieving sustainable supply pipelines underpinned by a robust and far-reaching learning, clinical learning opportunities, and then workforce development to upskill, retain and develop the workforce are key areas. Now, to do that, HE are working very closely with colleagues in NHS England and Improvement. In the East of England, we're looking at how we create a single offer, a single support package to support our colleagues and partners in systems in health and care. So we can underpin what the national ask is around some of the service developments and priorities with a robust offer to support the workforce, both to grow, to develop and to train. I'll stop there and I'll hand over to Paul, I believe, for the swim model, unless Phil, you wanted to add anything else to that?
No, Gareth, thank you very much. We'll move over to Paul Roach.
Thank you. That's great. Well, just Paul, if you would like to come on camera, please.
Thank you very much. Has it appeared?
There you go. Can you see your slides?
Yeah, I've got them. Thank you very much. Excellent. Well, thank you very much, everyone, for coming along for this session. I'm sure it'll be very, very interesting discussions. I'm just going to spend a few minutes talking to you about the system workforce improvement approach that we've taken in the East of England, and just share some of the initial findings and areas of focus that we're developing with systems. If we just move on to the first slide, please. Thank you very much. So what is system workforce improvement? What is the approach? It's a model that we first piloted actually in Hertfordshire and West Essex in this region. And it looks at developing ICSs, and it's very timely with, as Phil was describing, the legislation that's coming in now, and really starts to ask in a very structured way across pretty well all things workforce and workforce transformation, what would be required in a system to enable them to realise their ambitious plans for all of the workforce. And by identifying that, you can then turn that into recommendations and clear areas of focus. And then the most important thing is you can turn that into action. In terms of how it links in, the model has its own sort of language and 6 key areas that are described there at the bottom of the left-hand box. But what you can see above that is it very much is a health and care approach, and it very strongly links into, for example, the adult social care workforce development plan that was developed last year that has got 6 areas of focus. And also very strongly links into the 4 pillars of the people plan that came from national and all areas are developing. And the model is also referring to a very broad definition of workforce. It also looks at, for example, the voluntary sector, volunteers and carers as part of that broader workforce. And for those interested, it's a maturity matrix sort of model. So you're able to actually pinpoint where you are on a journey, as it were, from emerging where you've got some ideas all the way through to thriving where you're able to do all the things you need to do. You've got the resources, you've got the ability to deliver what you need across workforces, which may be 50 or 60,000 and more when you put all that together. So that's what we're trying to do, and we're working with all 6 systems and to help them to understand this and help them to do something about it as we come out of the pandemic. If I move on to the second slide, please. I thought it'd be useful at this stage. So we're just in the final part of what's called phase 2, which is where we're turning everything into recommendations just specific to each system.
Paul, you've gone on mute.
That's very strange. That happened to Phil as well. I haven't touched anything. How strange, the wonders of technology. I'll just start that bit again, but hopefully people heard the first bit. So essentially it's been turned, what we found so far from all of the work over the last number of months is specific recommendations tailored to each system, a framework for action so that people can understand and start to work out how to do something about these areas. They've already agreed a number of opportunity areas for consideration. And really then moving into actually realising the benefits, which will take some time. So we'll need to make sure we're able to understand that and help them to measure the impact. In terms of some of those emerging priorities that are coming out, one is around workforce resourcing and planning for the future, which sounds in a way a bit like a structural element, and it is, and it's about investment, and it's about have you got the resources that you need both at the centre but also within the system. And governance processes, but actually there's a cultural element as well, because it's all about how does the whole system come together around this agenda, around those transformation priorities that may be slightly different in different systems, and how do you ensure the sustainability of that. There's a specific area around cultural values and leadership that's coming out, and there are again different angles on this in different systems, but it's a mixture of things like values and behaviours. What do you want at a system level? What do you want at a local level? What's different about system leadership and integrated care leadership than perhaps organisational leadership? And also elements around how do you develop and grow that workforce through talent management at a system level, linking into the different partners. The third one is around equality, diversity and inclusion, perhaps not surprising at all and really important, which has gained momentum during the pandemic. I've never seen as much energy behind this area. But you know, how do you really create consistency of opportunity across a system, whatever sector you're in, whatever type of organisation you're in, and how do you ensure that you are reflective and representative of the population that you're serving? The next area is around supporting staff and creating opportunity, and I think this has probably emerged because of the acknowledgement of just what frontline staff have been through over the last 15 months. So again, it's really come to the fore, and it's a mixture of both health and well-being work and understanding how to support staff through, for example, compassionate leadership. But it's also around creating opportunities for people to grow and develop within a system, which presents many opportunities because of the number of partner organisations that there are, if one does it in a coordinated way. The next one is around optimising digital and technology as workforce enablers. So it's how do you bring those two big agendas together, and really looking at how digital can be an enabler of effectiveness for workforce and motivation and attraction and retention. It can also be the opposite of all of those things. So it's looking at how you work together to address that. There's an area around workforce data analysis and planning, and again this is very much linking into different elements of you have to understand what problem you're trying to solve to embark on transformation activity. So how do you do that particularly in a time with great unpredictability? And the final one, just to draw out, is around embracing the VCSE, the sector, volunteers and carers as part of that one workforce. So what does that mean? How do you support them? How do you develop them? How do you get their voice within a system? And how do they help to actually set that agenda fully, as opposed to being slightly on the side there? So that's a flavour of some of the areas, and we may well come back to explore some of those as we go through the session. And just the last slide, please. Thank you very much. So I guess in a nutshell, there is huge support for this work. It started at the end of wave 1. I was surprised myself at just how keen people were to work with us on this with such pressure on. But we do think it will help both to find a way out of the pandemic, but also take forward and pick up that whole transformation agenda and accelerate it. It has produced, through all the engagement related to it, a recognition across ICS boards, people boards, systems of how important workforces and people matters are. And as the recommendations are now being finalised, the focus is obviously developing clear actions to support the ICS development in this critical area. But the key thing, again, underpinning all of that is about implementation of transformation plans across a whole wide spectrum of workforce activities, and how do you make that sustainable and truly get the outcomes that you desire. Thank you very much. I'll pause there and hand on.
Thank you very much, Paul. I'm sure we'll come back and discuss this a bit further at the end of the presentation. So just going to hand over now to Lynn, who's going to be exploring the concept of executive clinical leaders in integrated care systems. Thanks, Lynn.
Hello, thanks very much. You'll see the first impact of COVID is that I no longer have a fringe. I was able to grow my hair, not going to the hairdressers for quite a while. So if we move on to the next slide, thanks, Rebecca. Great. So I just wanted to outline the sort of key rationale for integrated care systems. It's the holy grail, really, of health and social care internationally as well. And for England, that's the purpose of it is fourfold. So it's about improving outcomes and population health. It's about tackling inequalities. It's about best value for money, and also helping the NHS to support broader social and economic development. So bearing that in mind, a key area will be the development of effective leaders across systems rather than in providers and commissioners, as we have had in the past. Next slide, please. So we have a sort of map of England here, and we don't need to go into the detail of it, but there is quite a variation in clinical leadership at the executive board of ICSs as they start to mature and go into statute in April 2022. And so we have an opportunity in this time leading up to that to really think about how we strengthen the clinical leadership at executive level. Next slide, please. As part of my work that I've been doing with the Chief Nursing Officer for England and also the Chief Midwifery Officer, I've been working over the last few months on a Chief Nurse, Director of Nursing and Director of Midwifery career pathway, really making explicit what's probably been implicit across the systems about experience, but also taking that through to look at what a leader, exec leader in an integrated care system might need in preparation for these new and unique roles. So I've looked at the pathway from registration right through to ICS Chief Nurse. And in looking at that, I interviewed 33 key stakeholders, including chief nurses, leaders, HR leaders, and also accountable officers and chief executives, as well as directors of nursing. And in addition, I interviewed 11 directors of nursing and directors of midwifery who'd been appointed in the last 3 years to test out some of the things that I'd found as a consensus view from those stakeholders to see if that was really what people were feeling on the ground in action in those roles. I also interviewed more latterly 5 ICS chief nurses who maybe were in substantive or interim roles at the present. And that is sort of framework is outlined there. It's hot prior to press, as it's not yet out in the sort of full public domain, but I thought it would be useful just to show that we're focusing on roles and expectations, education and credentials, but also support to those individuals. And I suppose a few key areas that I would like to point out is that we're really looking in those senior leadership roles for broad-based experience, that people take those stretch opportunities and don't necessarily just go through a traditional route. So in terms of nursing, maybe through sister, charge nurse, matron on to a deputy chief nurse. We're looking for people who've had that opportunity to look more widely across the system and possibly do secondments, undertake work where they're leading improvement projects across the whole of the trust or across the whole of the system. Or maybe taken on a clinical fellowship or worked somewhere, maybe in Health Education England, taking those opportunities to think in a more broad-based way. There was a very consensus view that people would be operating at director level with a master's, and also a leadership programme had been undertaken, and that they would receive support commensurate with where they were wanting to be a director or working in an ICS, so maybe having mentorship from someone who was already an experienced individual in that area, or access to executive coaching. Next slide, please. So we looked at this stakeholder evidence, and here's just some of the key findings that we found. These ICS roles will be unique. No one has done these previously, and there is a much greater scope and complexity to them. I think particularly the individuals are likely to come from mainly a health background, and the understanding of social care in its entirety and the complexity of primary care and community services and independent sector is not to be undervalued. So what the key areas of leadership that they would be involved in as clinical leaders would be the integration of care, population health, quality oversight and improvement, and also engagement and co-production, and the healthcare workforce. And as you heard from the previous speakers, how important understanding about the health and social care workforce is in terms of leading the future workforce. Next slide, please. So we found that really we're looking for people with a plurality of skills and experience across a range of provision, and it's not just about that experience, it's about the ability to collaborate, influence, be politically astute, as well as having that transformation capability. So we're asking a lot of our clinical leaders within systems. Linking to the last speaker, a really important aspect of this role will be that equality, diversity and inclusion should be hardwired into the clinical leaders, and talent spotting and succession planning should be inclusive. So in the first year of working in an ICS, and these clinical leaders will have been appointed who have a considerable amount of experience already, what we've identified is that we really need to make sure there is a development programme of strategic leadership masterclasses, that there's an opportunity for experiential learning in areas where the individuals may be less familiar, that there should be coaching, executive coaching, and that there should be access to peer regional group support and a network for the ICS clinical leaders. Next slide, please. So we identified through the interviews a number of areas where ICS masterclasses could be accessed for clinical and, in some instances, exec leaders who are non-clinical as well, to assist them over this coming year in embedding their roles and understanding and sharing best practice. So there's some of the content that would go into the ICS masterclasses. And as people have got more used to receiving quite a lot of education online and virtually, I think there's a unique opportunity here to do that and share learning more widely. Next slide, please. So this is my last slide. It's one of the people that I interviewed. I have sought her okay to use the slide, to use her photo in her case. But here's someone who did work as back in her career. She was a head of midwifery in one of the Norfolk trusts, and she's now ICS chief nurse for South West London. Her name's Dr. Gloria Rowland, and she's both a midwife and a nurse. And as you can see, has a wide-ranging set of experiences, has worked across a number of systems, has worked in providers, and has undertaken masters and leadership program, and actually in her case a doctorate as well, clinical doctorate as well. So it just gives you an example of the wide-ranging background that is an expectation of a clinical leader, and they will still need support and enabling to undertake these really important roles in the future. Thank you very much.
That's Great, Lynn. Thank you very much for that presentation. We're going to move now into a session with Helen Oliver and Jessie Cunnett talking about reinvigorating the system with citizens at the core. Would you like to come on camera, both of you? Thank you.
Good morning, everyone.
Hello.
It's really good to be with you this morning. Thank you ever so much for having us. As Carrie said, I'm Jessie Cunnett and I'm Head of Health and Social Care at Traverse, and I'm delighted to be with
Helen Oliver. I'm the Chief Operating Officer at Eastern Academic Health Science Network, which is the kind of regional innovation partner for the NHS.
Great. And if you could go to the next slide, that would be fab. So as Carrie said, Helen and I are going to come at this from a slightly different angle and speak to the power of people and communities. And I guess one of the things that I would want to say right up front is that throughout my career, and whilst I'm at Traverse, which is an engagement, evaluation and research organisation, I've aspired to kind of contribute to a system of health and care by engaging people on health and wellness issues in the context of much wider values around human rights, justice, equality and respect for diversity. And I think something really powerful has happened through the last 18 months. And as this slide says, you know, sometimes crisis can be the mother of invention. And I think what we've seen through a kind of community and citizen response to COVID, we've seen that there is an enormous opportunity to take learning from the challenging time that we've had and to use that to inform and to continue excellent work that has started. As it says there, you know, since the outbreak of COVID, communities have been connecting, looking out for each other, and even more than normal, coming together in support groups, in action groups, and organise themselves so that there are over 2,000 groups listed now as part of the kind of mutual aid website. So there's been a huge kind of uprising really around community action, and people have been engaged and sort of enacted to see the power of their action perhaps more than ever. Before I hand over to Helen, who's going to give some examples in practice, we thought we'd give you an overview of perhaps 3 models that, well, big ideas really, that you'll be familiar with in part, but perhaps are worth really thinking about in terms of how we can support citizens and communities to move from being passive recipients of care to really active participants in creating and leading good health and well-being. So next slide, please. So I guess the kind of theme of what we were talking about here is the power of community. And 3 particular models that I think are worth us taking pause on and thinking about how to use as part of strategies and plans for reinvigorating the system across integrated care. Community development is a model and a framework that's been around for many years, certainly since the 60s. And the power of community at this particular time is ripe for models of community development. It's a process where people can come together to take action on what is important for them. And in practice, I guess community development supports communities of place and identity to use what they have, their assets, to improve the quality of their own community life. Brought together, communities and public agencies can then work in ways which are different and recognise different perspectives and can improve services together. So the kind of power of community development is something really worth exploring as a model to underpin other strategies. Co-production is something which is spoken about a lot, but often is one of those things which people feel is good words, but is not always backed up by action. And as a kind of additional way of acting with and supporting communities, co-production is something well worth considering. I think in my experience, it's often being seen as something you do as a way, as opposed to a way of doing things. And I think it's worth bearing in mind what real co-production is and how it can bring change about. The principles of co-production, as a reminder, are around recognising people as assets, seeing people as equal partners, and seeing their ability to help shape and inform and improve services. Building on people's capabilities, so recognising that everyone has something to bring to the table, not focusing on what people can't do, not focusing on illness or things that are lacking, but focusing on what people can bring to the table and the things that they have to share. This concept around two-way reciprocal relationships, it's recognising that there is a mutuality. It's rebalancing the power and shifting things so that people feel much more on an equal footing. Encouraging and promoting peer support networks, or promoting and supporting the value of the networks that we as community members all exist in, seeing how those can become valuable contributions, and actually investing in those and creating situations where they can grow. Blurring boundaries between delivering and receiving services, seeing the value that each person has to play, or each part of the system has to play, and seeing citizens as a fundamental part of the system. And then perhaps lastly, in terms of the kind of co-production principles, this idea about facilitating, not delivering to, speaking to this point about doing with and not for, enabling people to be active rather than passive. The last model that I think is worth us really thinking about in the light of COVID is community resilience. Community resilience is a framework which is drawn from a kind of participatory approach to emergency management. And there's something quite interesting to look at in terms of the ability for the community to act as resilient partners. There's some really interesting work being done in Brighton by the Boing Boing network, and I can post a link to that if people are interested. They've developed a resilience framework, and they've developed a model of working with marginalised communities around this idea of resilience, community resilience. So I guess lastly from me, before I hand over to Helen, I think there's a great opportunity to really value citizens and communities as part of the shared leadership model. And they can really help to solve some of the big issues that we have in terms of reinvigorating our systems. So over to Helen, who's going to talk about it in a bit more detail.
Lovely. Thank you, Jessie. Can we just go to the next slide, please, Rebecca? Thank you. Okay, so building on what Jessie said, we've loosely bucketed into 3 areas where we think citizens have a really key role to play in shaping our future services and also the workforce in response to that. So broadly speaking, there's an area of work that we could do around greater self-care activation of the communities and the populations that we serve, because if we're able to support people through, and it might be technology, it might be through service change, but if we're able to support people in the communities to stay well for longer, then that will reduce the overall demand that we're facing, and also enable us to think differently about the services that we offer to the communities and individuals. So there's one great opportunity there really to try and really focus down on self-care and activating people to be better and more resilient. Then there's a second area which we think is really interesting around how we can increase the community as a larger unit to be more activated in terms of their local communities. So that might be through things like volunteering, which we've obviously seen masses of during the pandemic, but it might also be in relation to smaller communities and neighbourhoods coming together to offer support to those individuals in the community that require a bit more help. And then finally, the final bucket is around co-production. So this is sort of building on the stuff that Jessie was just speaking about. But in terms of, you know, we are probably facing the biggest challenges we've ever faced in the NHS now as we rebuild. So we've got a massive workforce shortage. You know, we've got huge challenges in terms of how we redesign services to meet this, you know, growing demand that was there before the pandemic and is increasingly so now. So how is it that we activate our communities and our citizens to work with us as we develop those new approaches to delivering services and the new types of hybrid roles, for example, that may be required as we go forward into the future? So really working in in a shared way with the population to say, what are your tolerances to different service model types? How might we completely, review the way in which we deliver some services in a way that is more efficient for us, but it's also a better outcome for you guys. So it's really about how do we activate people to be in the room with us as we start to redesign and improve services. So next slide, please, Rebecca. So here I'm just presenting just a few case studies of what we've done in previous places and previous projects, just to give you a flavour for the sorts of things that I'm talking about. So the first example is the Self-Care Youth Hackathon, and we ran that with a local youth group and Form the Future, which is an organisation which basically works with young people around trying to get them into new careers, etc. So we basically called together a group of young people and we spoke to them at the start of the session around mental health and the issues that that sort of the system was coping with in terms of demand for mental health services and a particular focus on young people. And then we basically ran a hackathon with those young people to develop ideas that they felt would be more suitable types of offers for them. And if I say the responses we got were absolutely fascinating, things that we would never have dreamt up as a group of people sitting in a room at Eastern AHSN, really, really imaginative solutions, which, as I say, we would not have got anywhere near unless we had convened that group on that particular day in that particular room. So that for us taught us that if what we're trying to do is be truly innovative, then we need to get particularly young people in the room to think about what services they want to be available to them as they move through into adulthood. The impact of that hackathon was that we then presented that information back to mental health commissioners in the region to say, this is what young people are saying they want. And we leave it there. But, it was there, the intelligence was there for individuals to really kind of mull over afterwards. The second example that I've put there is actually from a previous role at Care City in Barking and Dagenham, where it was a really lovely example of community asset mapping and the consequence of the kind of activation after we presented the information back to them. So we basically went into the Gascoigne estate. For those that don't know, Barking is a bit of a hairy estate. We went in there, we mapped everything. We spoke to the pub landlord, the fish and chips shop owner, the postman, the lady that ran the creche, everybody, to really understand what infrastructure they had as a community on that estate. And then we convened that community together in the community centre, and we presented to them some statistics that we had gathered around loneliness and isolation amongst older people living on that estate. And basically said, at the moment, it's costing us as a system, I think it was something like £5 million to provide services to this estate. But it's not working because we've still got so much kind of isolation and mental health issues. And they basically came up with the answers for us. They suggested opportunities that they would volunteer, that they would take dinners around to people's houses. And interestingly as well, they also were able to identify a critical mistake that had been made in the commissioning process, where I think they were spending about £190,000 a year on a mental health service for older people, but no one was going. And they sort of said, we don't understand, we're spending all this money, we know it's an issue, but nobody's attending these services. And they were able to tell us the reason why people weren't attending was because it was in Dagenham. And they didn't go to Dagenham, so it was something as basic as that, that through talking to the community in which we were serving, we really got to the bottom of what one of the major issues was, services that we were commissioning. And then the final case study, just to highlight, is a piece of work that we've been doing in Cambridge and Peterborough around co-production using the model of participatory appraisal, which Jessie referred to, whereby you recruit a group of very well connected individuals in a community sense, so not necessarily people that sit on boards, but people who just know the area, know the mums, know the elderly, are really kind of well connected in their community. And then we trained them in the art of participatory appraisal, which is basically facilitating workshops. And then they went out and facilitated loads of workshops and brought back intelligence to then inform the development of a community hub on the North Stowe estate, which was a brand new estate being built in Cambridge and Peterborough. And the end result of that was brilliant. One of the things that they highlighted was that they needed some specific services for young people around their mental health, coincidentally bearing in mind the hackathon. So we fed that back to the commissioners, and they then went on to commission a service which is now really, really well taken up and showing really, really good signs of having, you know, massive impact on those young people that attend it. So again, it's all about getting to the heart of what the problem is, talking to the community and co-producing with them. So next slide, please, Rebecca. Okay, so finally, I've just as you know, we probably don't need this slide because it's quite obvious, but I've just captured there the benefits then of this type of approach. So there's obviously a huge potential to divert or reduce demand if you do this well and you do it in a meaningful way. It's also a really good way of ICSs in particular being able to demonstrate that they have got a commitment to patient and public engagement, and further down the line negating some of the issues that you sometimes come across when people then say, oh, we haven't been consulted. So it's a really important way of being able to demonstrate that commitment by actually doing it. It's also great in terms of being able to make sure that diversity and inclusivity is covered off at all angles as you develop those services. And particularly following COVID, with the amount of health inequalities that have been exacerbated, that is front and centre of most ICSs. It also gives you an increased capacity for new service solutions because you've obviously got lots of different ideas around the table that, as I say, you might not have come across. It gives leaders an opportunity to learn from user experience as well, as I think, you know, all of us in leadership positions sometimes do feel a little bit remote and removed from the front line. So it gives you that fresh input of service user views, gives you an opportunity to lead and build on best practice around involvement as well. And it also helps you to improve the quality of patient experience, which obviously feeds then into very obvious performance targets, etc., that we all have. It also contributes to workforce development and well-being. I think staff get a real sense of joy, I think, generally out of working with the public in these types of meaningful ways, and it helps them to connect again to the mission that we all have to serve our communities. And then finally, it contributes to cross-cutting local objectives for the community wellbeing, regeneration and community. So it really does have that broader sweep across the whole of the ICS partnerships in terms of making sure that we're working alongside our communities to regenerate and to design services. So next slide, please, Rebecca.
And I guess I'm going to pick this one back up. So I think this is really just to conclude, and we've got the questions that Carrie's already mentioned, but in addition, we thought we'd pose a few more sticky questions around some of these things on the basis that maybe one of the biggest criticisms that gets rallied by the public when they are engaged by systems is that it feels lacking in integrity or depth, or it feels tokenistic. These questions are aimed at just trying to help us to think a bit more deeply. So Carrie talks about flipping the model and, you know, putting different people in positions of driving change. So I guess questions that we thought would be useful to pose are: what needs to happen to create the conditions that enable communities to really locate and use their assets to improve health and care? Second one, in the context of integration, how can we challenge integrated care systems to see and view the role of citizens as an integral part of the leadership system? And then the last one there, if health, public services and voluntary community and social enterprise organisations make up broadly 3 different sectors, what needs to be done to acknowledge and nurture citizens and communities as a funded and resourced fourth? So just a few concluding big questions that we're not expecting answers to, but hope will give people something to mull on after the end of the session today. Thanks very much.
Thank you.
Thank you, everybody. I don't know, Rebecca, if you'd like to flip on to the next slide, please. And the next one. Okay. I'm going to hand over to Jonathan and Sally, who are going to just facilitate a bit of a discussion with the panel about some questions that have come up, first of all, in the chat box. And then once we've had a look at those questions, we had actually set a few questions that we wanted to share with participants today ahead of the session. And these are on the slide in front of us. So we thought we might just set a bit of a challenge in terms of a Mentimeter activity. So you'll start to see these questions dropped into the chat box on your right-hand side. And we'll give you an opportunity to link onto the Mentimeter and contribute to some answers really to those questions so that we can utilise that as the focus of discussion with our invited guests. So I'm going to hand over to Jonathan and Sally, and I will participate obviously in the discussion just shortly, but a massive thank you first of all to our panel, Phil, Gareth, Paul, Lynn, Helen and Jessie, for a really stimulating presentation. So let's get talking about some of these very thorny issues. I think there's a lot of interest I can see around citizen engagement, so I'm sure that that will form quite a strong thread. So over to Jonathan and Sally.
Okay, thanks, Carrie. So Sally, shall I start? Lynn, there's two questions for you that came up in the comment box. If I can pose those to you, if that's okay. So firstly, it was a question raised actually by Carrie, but around professional groups and integrated pathways as part of a view and focus around clinical leadership across ICSs. You know, do you have any thoughts about that, Lynn, around engaging with a wider professional group?
Yeah, in discussing with others whilst I've been speaking with stakeholders and directors and things, what's quite interesting is where it's not about representation at the exec or on the ICS, it's about working together in a sort of interprofessional, multidisciplinary way, and having an opportunity for those individuals and leaders to work together collaboratively. I suppose where I've seen it most effectively work, where an international model was at Christchurch and Canterbury in New Zealand, and developing those relationships with those senior clinical leaders so that it almost becomes like one voice. We're working on this pathway or population health issue together, rather than this is what the physios are doing or this is what the nurses are doing. So it becomes almost like an agreed pathway or clinical approach, or the way that you're working together with the managers and things. So so I think a number of the ICSs have a sort of a clinical grouping that is a sort of almost like a subgroup of the ICS, and that may be one way in which you can do that and work effectively. But I think it becomes really a whole mind change set in the culture of working in a system. What I felt was that you end up moving away from, when I looked at in New Zealand, you move away from this idea of I work for Maud community provider and become I work for the Canterbury and Christchurch system population. And so you move away from that whole sense of what do we as a provider do to what can we do for the whole of the population and for the individuals that we care for and treat. So I think that's where we need to start looking. We shouldn't be too siloed about the clinical leadership. We need to all work together, but we need to do that very much working within a mechanism that's about a culture where we're all working together in the system.
So probably, Lynn, as you'd expect me to say, around care, sort of clinicians working across the care sector, what were your thoughts and experiences of hearing those voices of a group of a huge number of clinicians, nurses and other clinical professional groups, but sometimes whose voices are less heard across traditional models, you know, sort of or traditional approaches around system leadership? What were your thoughts about that?
Yeah, I had an interesting discussion, for instance, with Deborah Sturdy, who's the chief nurse for social care, about how we might hear the maybe less often heard voices around care, in domiciliary care and in care homes and those sort of things. And I think there is something around the type of leadership approach that we use, and I know in the text we've been hearing about sort of collaborative, person-centered leadership. And I think there's something around the shared governance idea, that you have the opportunity to hear the voices of people at the front line, wherever they happen to be working, and how important that is to the decision making about things. So one of the things that Deborah and I talked about was the opportunity for maybe an ICS chief nurse to have frontline staff within the care home sector and other areas in a sort of almost like an advisory group, so you can work together with them rather than it being very much a top-down approach to the way that you identify how you could improve services.
Thank you. And the other question, Lynn, that I've picked up from the chat box, and you've already sort of made reference to it, was raised by Joanne Bosanquet from the Foundation of Nursing Studies, is around the integrated skill set for person-centred sustainable transformation. You know, those key elements and key skill set to enable that. What have been your experiences so far with this work?
I think there's a huge we were going, I think, in the NHS and, you know, on a journey really about leadership and a movement from maybe what might have been in the past sort of command and control to a much more collaborative, a compassionate leadership approach. I think COVID has created quite an interesting situation where in part some of it had needed to be command and control early on around, you know, setting up systems for Nightingale hospitals and things. But having said that, what was interesting is that those systems that and areas that handled infection control and COVID quite well, some of those have talked about, for instance, that they it was better where there was a less bureaucratic sort of more flattened hierarchy, and that people who were leading were very much hearing the voices at the front line. And so I think that that probably bodes well, that we're transitioning our thoughts on how we might lead in the future within health and social care. And so lots more to do, and it isn't something that you just learn through going on a course. This is something about the way that we think about things and the way that we value and the principles of the way that we lead. So and that's something we can work on together as a whole set of leaders.
Okay.
That's great. I think Sally's got a couple of questions there, Jonathan.
Yeah, so Sally, would you like to pose your questions?
Thank you. I'm trying to look back where I wrote it now. There were some questions arising at the beginning when Phil, Gareth and Paul were talking about how do we ensure that we're making new connections, having new conversations, bringing new groups like charities and citizens, as we've heard, into the mix as ICSs continue to mature. So I don't know whether you guys have had any thought on that.
I can certainly give often a view around, certainly as we plan going forward, and something that I think we've certainly learned through management of an incident of COVID through the pandemic is we plan through different lenses, and we plan workforce through either place, pathway or profession. And I think recognising that levers around workforce are held by different agencies. It's not just one organisation or one body, all with different and relevant timeframes as well. So I think in response, Sally, I would argue it is that planning around workforce at a place level and having real clarity around who is involved, the alignment and coordination of that planning at a place level. As well. I think too often we clearly will see national mandates given through pathways and through professions, but I think the going forward we'll certainly see a stronger play of planning around a place and clearly having clarity around who those stakeholders are at a place level in order to plan that workforce.
Thanks, Phil. Gareth, you've got your hand up. Did you want to come in?
Yeah, just to add to Phil's comments, really, just some of the conversation we're having with systems is around how we we do planning and we look at transformation beyond the usual conversations with the usual suspects in terms of HR and workforce specialists, and which absolutely need to happen, but there's increasing opportunity and we're seeing increasing energy around engaging with clinicians and team managers and the workforce, and more so we're hearing today a bit about engaging with the communities we serve around what should that workforce look like, but more importantly what training and competencies should that workforce have to deliver both the outcome in terms of treating whatever the need is, but also the experience that patient has, because actually the workforce societal on both those being really important. HE are supporting a model of workforce planning called the CLEAR, which is working with clinicians to lead on workforce planning and transformation. So actually it's done at grassroots level, and we know when we do planning rounds, when you talk to team managers and clinicians that are living and breathing, often they know the solutions. It's the process and limitations of funding and all the other challenges we know and love that exist that stop us from doing things sometimes that are more innovative. So actually engaging in that wider workforce and as Phil says, working at a place-based level to help them have a voice. Actually the solutions are probably there, it's just about allowing them to come to the surface.
Yeah, thank you. I'm very aware of the time. Carrie, am I allowed to bring Paul in? He's got his hand up next.
Yes, of course.
Thank you. Paul, did you want to comment as well?
Hi, thanks very much. Yeah, there's a lot within that question response so far. Just a couple of thoughts really. It's interesting when you look across 6 systems, you can see those differences and similarities. So if you look at systems that can clearly describe a sort of enabling leadership style, sort of compassionate leadership style, a sort of 21st century leadership style, and you can see people enacting it with all the engagement that we've been doing. You see them reaching down to where the real work gets done much more. So I think you can create cultures where actually you can listen to the voice on the ground. I think the other big opportunities that are coming along in terms of ICS responsibilities, again, you can see when this is really embraced, is if you understand that you are anchor organizations, you are the largest employer in the community, you take on that community responsibility, especially with the scale of ICS and the place within them, you can actively see the difference of the voice of the community and the voluntary sector at very high levels within the ICS. Where you haven't fully got to that point yet and fully embraced it, then you don't see it. So it's kind of interesting. There are differences, but I'm quite optimistic because you can see where that's starting to work already, even these early days of ICSs.
Lovely. Thank you, Paul. Back to you, Carrie.
That's brilliant. There's a really good question here from Julian Wynn, who's saying that there have been several mentions of co-production in problem solving. And Julian would like to know what the panel's thoughts are on the value of divergent production to achieve workforce and other objectives. And I'm just wondering if that's something that Helen and Jessie would like to start off on before we have a look at the Mentimeter questions. I'll put you on the spot. Nothing like looking on the model.
Not to speak for Helen, but what would be really helpful is the person that asked that question could just say a little bit more about what they mean.
Yes. Julian, would you like to come on camera and tell us what you mean?
Well, certainly come on microphone, Carrie. I'm sure you want to see me. Yes, divergent production is kind of the opposite to co-production. It recognises that there's a problem that everybody agrees on, but in divergent production systems, people take very different solutions to the problem, and so you get a lot of different ways of solving the problem that people have got in mind, rather than co-production where people tend to have agreement over what the solutions should be and then work towards those solutions. So that's what I mean by divergent production, taking different approaches to solve the same problem.
I think any way of getting people thinking more laterally around these big challenges is to be welcomed. So yeah, I think that's a great approach. And often when we're looking at sort of broader innovation challenges, that's the approach we take, where it's literally you know, blended approach using lots of different, you know, methodologies, frameworks to really kind of stretch us in terms of our you know, innovativeness, really. So yeah, no, I'd absolutely agree that it would be a good idea to try and apply some of that too.
And I think the only thing that I would add to that, and I think it also reflects back a bit on something that Stu West's question, hi Sue, that you posed earlier on as well. And I guess this is also a slightly tangential response, but I do feel like there's something about if we can move away from seeing health and wellness as about the services that we deliver and much more about the lives that people live being healthy and well, then actually we can engage people in different problems in different ways, because they are able to connect, or we can, and I talk about, you know, me as a person in the community, I can connect things that are relevant to me in my life, because it's about more than me going to a service that's already predetermined. It's about my perception of being a happy, healthy, well functioning person in my community. And I think if we can try and be more connected to that, we will avoid some of the pitfalls that we come to around how we try to retrofit things we've created to meet people's needs, and then we have to go back around the houses to invent some new way of working with people to help them to do something which is ultimately pretty simple if we go back to the basics. So Sue's question about should it start in schools, yeah, it should definitely start in schools. And I think if we're focused around the stuff that really matters to people in terms of being healthy, happy, well educated, you know, well fed, loved, all of those sorts of things, then it sort of automatically starts to become a part of life, including school, out of school, before school, you know. So I think yeah, it's a big response, but I think it's one that we can easily lose sight of.
Absolutely, well said, Jessie. The younger we start, the better. Definitely. So yeah, Sue West's question about school-based curriculum and activities and opportunities to connect all ages is really crucial, with a focus, of course, on wellness as opposed to illness. And community health and well-being, community development. I'm just wondering now, it's 7 minutes past 1. It would be really useful, Jonathan, Sally, if we could look together with the panel at each of the responses to the Mentimeter questions. So I'm just going to ask Heather if she could drop the response for the first question into the chat box. Is that possible, the link to that?
Sorry, I'm just bringing up the live results. So I can't drop them into the box, but I can share my screen.
That's great, thank you.
Okay.
If we just remind people to keep their cameras off, that would be great. Oh, that's brilliant, thank you. So we've had 15 responses?
Yep, that's right.
Yeah, so in terms of the priorities or the opportunities for systems transformation, then the emergent themes seem to be a focus on technology and e-health and resources. There's quite a big theme there around digital technology, isn't there?
Yeah, use of digital technology, fast-paced activities,
Yes.
Greater consultation for remote working, new connections. Yeah.
I can see also that there's a focus there on the right-hand side around rehabilitation and design of services to meet the needs of our populations around long COVID. And that's actually really quite interesting, because certainly we've had a look at some population health data about the percentage of unmet need for people with long COVID and people who had long-term conditions previously. So that the percentage of unmet need is a hugely diverse issue across Norfolk and Waveney ICS in particular, but will be a challenge for all ICSs in the east of England and in other regions.
Yeah. Shall we do the next one? I'm aware of the
Yes,
time.
please. Yeah, that would be good.
Barriers. Practitioner mindsets. That is amazing that that's come up first, because I do remember starting the no smoking campaigns in hospitals, and largely it was the practitioners who were very anti, and we had to do a lot of work to change the mindsets of the practitioners to initiate that, I seem to remember.
That's quite an important point, because a lot of the, I don't know if Paul, Phil want to come on camera or make a comment about this. I mean, a lot of the work that's happening at the moment, or even Lynn, is indicating that practitioners are quite stuck in terms of their allegiance and identity in systems transformation. They're not quite sure about whether they belong to an organisation or a service or a system. So there's an awful lot of identity work and development work to do if we are to be truly inclusive in terms of leadership development for ICSs. I wonder if our colleagues have any comments to make about that from the panel.
And it links to what Lynn was saying as well about compassionate leadership, and that's been picked up in the chat. You know, how do people sustain their level of compassion? And again, we've seen that, haven't we, over the pandemic? Particularly, again, there's a comment there about mentorship and providing that infrastructure of support for people. I'll just check who's got their hand up. Paul, did you want to come on camera?
Hi.
In response? Thank you.
That's a couple of thoughts, I suppose. On the practitioner mindsets, I think it's interesting. There's two different things, I think, because I think if you look at what has happened during the pandemic because of the emergent situation, I think people have started to think less about, you know, what was I trained to do? This is my job. I'm the only person that can do it, maybe. To, you know, how do we come together to achieve the task of supporting it within the crisis? So there, I think there has been a change in terms of behaviours that a lot of people have seen. So there's that's one element, which is how do you then continue that if you think that's a good thing, which in terms of integrated approach to care, it generally could argue is. I think the other thing, which is much more perhaps of a strategic change, is I remember when I was doing the London-wide workforce work, there was quite an interesting challenge there, which was the increasing specialisation in terms of education and so on. But an increasing requirement on the ground often for generalists. So I think there is also something about how do we educate and train the clinicians and practitioners in the future, with them working together as a core element of that. So just some thoughts on that one. There's many more we could discuss. On the first slide, on the digital, that's come through loud and clear around the, you know, how digital could improve your retention, your attraction, your effectiveness in terms of working, and the impact of that, positive impact on service users. But the other side of that is there is quite a range of capabilities within the workforce in terms of digital. Therefore, you have to actually have a learning and development approach to ensuring that all of your staff, whether in health or care, can actually work with the new technologies and so on. So there's quite a lot to do to sustain that one as well, I think.
I think there's an important point there that somebody made about not all citizens and people can get involved or feel confident in using digital tech. That's the first point. And Jessie's just made a very important point about working with people who get stuck in complexity of systems. So focusing on health and wellness and what matters most to people is really important. So that's, you know, when we talk about flipping the model, it is very much about citizen-led. Jonathan, you've got a point you wanted to make there as well.
Yes, Carrie. Yeah, so I was just thinking just around what we were saying, and I think it probably links back to something that Lynn was saying earlier on around sort of flattened leadership and learning through COVID, but how practitioners are liberated to think and work in new ways through the leadership they both experience and the leaders they are. And I think there is absolutely an intuitive link between both parts. that leadership needs to absolutely enable people to feel liberated, to be able to lead and feel enabled to do that.
Perfect segue. Lynn, you've got your hand up.
It's just a quick point, really. Some of the things that happened in New Zealand moved much faster because they had an earthquake. And in that moment, they took a chance on doing things that might have taken a year to put in place. They put in a matter of days. Well, I felt like COVID, in a way, has led us to do things like that within the NHS, you know, digital consulting, these sort of things that might have taken a long time to happen, say in primary care, have happened at speed. But so that's been great that we've been able to do that. And we have to sort of reflect on, we shouldn't just go back to our old ways. And we've got a huge recovery that we're working on at the moment. And I do think within that recovery, we can't lose sight on the well-being of staff. And I think, sadly, the well-being of staff has maybe not been to the fore in previous leadership models, but now actually is probably the priority around making sure that the population is well cared for, that we also, part of those population are also our health and social care staff. So we need to start thinking really seriously about how we make their working lives as good as they possibly can be, especially when we've got such a number of workforce vacancies.
Yes, absolutely. Thanks, Lynn. And there is a big drive for investment by the NIHR in solutions to support the well-being of staff. But I think we should move on, Sally, to the next one, please.
Lovely. Yeah. Next question should be priorities. Okay. So not so many people got through to this question. And what we're seeing here is people talking about communication is a big one, and how we gain mutual understanding and expectations around both opportunities and limitations of people's roles in the workforce and the skill sets that they've got. Looking to see how we all fit together. And again, I think we're beginning to see, certainly in HEIs, how more and more confident people feel now coming together as interdisciplinary, multidisciplinary learning opportunities, and seeing where they complement each other. And I think some of Kim's work, Kim Manley's work, has shown that at consultant level, and when you're working in effective workplace cultures, there's a huge respect for each other's contribution to the care and the pathways that clients and patients are taking. MDT working, and also the link coming through, which seems obvious but is not an easy answer necessarily, is how health and social care is coming together, particularly through the investment that we need for our care homes and residential homes, special schools, learning disability and maternity services, which are key priorities for many of the systems that we're working in.
That's a good segue, Jonathan, maybe just to mention the Teaching and Learning Care Homes initiative.
Yes, so this is a national programme that has been run by the Foundation of Nursing Studies. We have been commissioned working, so we as in the Impact Research Group, working with the Foundation of Nursing Studies, have been commissioned to deliver the programme across 5 care homes across Norfolk and Waveney, commissioned by Norfolk and Waveney CCG. So that's going to be a great opportunity to really support and work with, albeit a very small number as a starting point, but of care homes across the system, which is going to be really exciting.
That's great, thank you. Can we move on to the next one, because we've got about 11 minutes left. So we've got the executive clinical leadership. I don't know how far people got with these, because it was quite a tall order.
Yeah.
That's interesting. There's a comment there about abandoning the concept of 2 boards at each ICS. I don't know if Paul, Phil, Gareth or Lynn or anybody else would like to make a comment on that. And also there's a comment there about seeing clinical and systems leaders within each ICS. Could they not be, my question would be, could they not be the same thing? Why would they need to be separate if we're trying to drive integration?
Carrie, can I just mention because I wrote the comment about the two boards.
Okay, yeah.
So yeah, the proposal is that we have a board for strategy and decision making, another and partnerships, another one for finance, so finance and decision making and strategy and partnerships. It doesn't make any sense to me if we are talking about integrating care systems and then we separate out functions at the very top that seem so interdependent. And I'm kind of baffled by the whole thing, but I'm sure that somebody from NHS England may be able to put me right on it. But it just seems crazy to me to be talking about integration at one level and then separating out at the top of the management tree.
Yeah, well, that's a classic example, isn't it? I don't know, Paul, have you come across this in your work so far?
Hi, Carrie. Yes, I suppose my sort of comment, I suppose, is certainly within the work we're doing, we're obviously not in control of the white paper and what the legislation says. So I'm not exactly sure of the, everything that's beneath where that's come, which is where that concept has come from. I think the key thing, though, is that whatever the, should we say, governance arrangements that end up getting proposed or agreed through Parliament, etc., is that unless the social care voice is as strong as the health voice, and it truly is all together around both boards or the board, that to me is the key. And certainly some of the conversations I've had is if there is that separation, and what you don't want, and systems are saying this, is what they don't want is a strategy board that's all health, and then they'll bring in the partners in another board type thing.
Yes.
It's about the voice of all the partners in the main board with the financial accountability. So that may be the fix, but again, I'm not quite sure of the logic of why it's being proposed as it is, but that's what people are starting to think about already in terms of how do you maintain integration within that.
That's very interesting, and I guess my sub question to that would be where's the citizen involvement on these boards? I mean, are the ICS boards actually including citizens as an active part of the board infrastructure?
I think they're all in different places. I think they all have a strong desire to try to get the voice of citizens in the system. And some, being a maturity thing, some are more further on in that than others. One of the challenges with that, and certainly in previous boards I've been in, we've had that sort of voice somewhere in and around those tables. The challenge is how do you get a voice that's reflective of a community, which is such a diverse community. So I think there are challenges, say, in having an individual, as it were, but having mechanisms to ensure that you do reflect the voice of the public that you're serving is the key thing. It's finding the right mechanism, maybe.
Yeah, that's great. There is some questions about citizen involvement in a minute, which we'll just go on to, but there is a very good question and a good challenge to me, actually. I think it's because I'm so used to talking about clinical systems leaders, a good question, a challenge that why are we talking about clinical when we're talking about ICS and population health? So acknowledge that's my own assumption and propensity to be thinking about clinical because of the context in which I've been working, but quite right to bring me up on that. I don't know if any of the panel wants to.
I think it depends what you mean by clinical, and I suppose within this context, I mean, it's broader sense. So it's where someone is involved in the care, delivery, and treatment, or meeting the health and social care needs of individuals. So I suppose it's a sort of maybe an imprecise term, but it's quite a difficult one, where you may have, for instance, a system exec that might not have anyone from a delivery standpoint who's involved in delivery across a person's pathway. So it could have a finance, it could have an operations, it might not have. So I think that's probably why we're tending to use the clinical, because is to have voice of practitioners within whatever circumstance. But I can see that you know, and sometimes clinical becomes synonymous with medical, for instance. So I think the terminology is an interesting one, and how that might work through and play through with ICSs.
Yeah. If we flick to the last questions around citizen engagement, there's a really good point here from Helen. Helen, I don't know if you want to come on camera, just responding to what Paul was saying around not just being tokenistic with citizen involvement, but finding mechanisms to co-produce with citizens continuously is really important. I don't know if Helen and Jessie want to come on camera and just have a look at some of the questions or answers that have come up in relation to this particular question.
Yeah, I think it's about using every opportunity as the partnership develops to make sure that you're co-producing effectively. So Paul is absolutely right. It's not about having a person that represents the views of a population of millions. It's about making sure that you've got the links into the community to be able to go to them with the challenges and ask for them to help you to solve them. Yeah, and as you say, that's great. Be part of the change process as co-creators. That's exactly what we're talking about. So it isn't about, I've certainly worked in some organisations where people come along to a PPI group and present their idea as a kind of, do you like it type thing, as opposed to, do you want to help me develop it from the start? And that does mean that it limits the effectiveness of solutions. If you just go at that end point and consult, it's much more efficient if you can get people to feed into it throughout the process.
Yes, and I think we have got a real responsibility also to enable citizens to develop the skill sets, to enable them to be independent and more influential in decision making and policy making and design of services locally. And of course, the biggest challenge we've got is the stuff that's around us day to day, which is all the data that we collect from patients, I hate the label, that we don't use. So, when we go to commission workforce development and transformation, we don't start with the data that patients and citizens give us around friends and family tests and staff satisfaction. We never look at that data, and yet it's sitting there. And it's really vital to enabling us to do things differently, I think. So, of course, that's a shameless plug for a paper that I've just published, which I'll send in the link chat afterwards, which is 7 challenges for engaging citizens in CPD commissioning for our Health Education England colleagues doing things differently. I don't know, Sally, short on time, aren't we?
Yeah, Phil's got his hand up, Carrie, if you could bring him in.
Hi, Phil. Sorry, I can't see my screen.
It was just quickly, I suppose, linking back to Julian's point, obviously, if there's around the 2 boards and influencing and being able to enable citizens to influence as well, it is really down to those systems. And although, yes, the bill was quite, as Paul said, is yet to be discussed further in June in Parliament, but if one board is around the governance and the performance management and, in essence, of the spend of through finance through to national NHS, but the other board, the Healthcare Partnership Board, is to be shaped by those ICSs going forward. And really, if that board is to look around developing a plan that addresses the needs of the local population, it comes back to that subsidiarity and planning at a place level. And the actual ask through that white paper is that it's down to the systems as to who they want around the table to have those discussions, and the encouragement that citizens influence that further. So it's really in those systems' hands to enable those citizens to come forward.
That's super. Thank you, Phil. Thank you, Sally and Jonathan. And Heather, if we could just go to our last slides now. We come out of the Mentimeter and go back to the slides, please. I'd just like to say a massive thank you to our guest panel today for taking the time to present their work and their thinking. We could go on and on and on, and this is just the start of the journey. But I think that the most important thing is that we all offer a diversity of experience, and it's how we work together to make the most of that to drive transformation that meets the needs of our local populations. That's really crucial, and that requires all of our integrated skill sets. But particularly requires us to think about how we co-create things in a really authentic way and help our colleagues to develop the skill sets, the integrated skill sets that's required for system transformation for the future. So we will continue to work collaboratively with all of you as the Impact Research Group at UEA. A massive thank you to all the questions from our audience, and we will pick any up that we haven't answered and put those to the panel and come back to you with some answers. But as we're out of time, I'm just going to do a plug to the next webinar, which is called Finding Nemo, and that's leading and facilitating culture change, a whole system approach, facilitated by Professor Kim Manley and myself on the 22nd of June at 12 o'clock. And that's just a 1 hour session for our next session. So we look forward to seeing you all there. We will post links to publications and make sure that the wonderful examples that our colleagues, our panel have given today are available to you. And a copy of the presentation will be available through our YouTube channel shortly. So if I just invite the panel to come back on screen, and if you could just come back on camera. And we just say a massive thank you to you all. Thank you so much for your time. If you'd like to stay online when everybody leaves for a debrief, that would be fantastic if you've got time. And we'll just say goodbye to our audience. Lovely to see many of you, some well-recognised names we haven't seen for a while. So particularly our colleagues from Kent and Canterbury Christchurch University and further afield. Thank you so much, everybody.